Okay. Good evening. My name is Monica Anzalone, and I am Program Coordinator for the Epilepsy Foundation of Connecticut, where our mission is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. Welcome to tonight's webinar presentation on febrile seizures. And tonight we are going to learn what febrile seizures are, their relationship to epilepsy, and that will include risk factors and long-term impact. Presenting for us tonight, we have Dr. Lila Worden, and she is a pediatric neurologist at Connecticut Children's, and she specializes in epilepsy. Prior to coming to Connecticut Children's last summer, Dr. Worden trained at Children's Hospital of Philadelphia and at the Massachusetts General Hospital. She has a special interest in dietary therapy for epilepsy and co-leads the ketogenic diet program at Connecticut Children's. Here she takes care of both adults and children on diet therapy. She's also involved in clinical research on the ketogenic diet and studies how best to implement the diet. And so we're happy to have her here this evening. Just a few housekeeping reminders here. This webinar is being recorded, so this will be available on our website and will be posted to social media. So for the purposes of sound quality, we just ask that everyone remain in muted throughout the presentation, and any questions that you might have throughout the course of the presentation, please type those in the chat box and we'll make sure to answer those at the end of the webinar today. So I will go ahead and let Dr. Worden start us off for tonight.
Great. Thank you so much, Monica, for inviting me, and welcome everyone to a seminar about some hot stuff. So we're going to talk about febrile seizures tonight. As Monica mentioned, my name is Dr. Worden. I'm one of the pediatric epilepsy doctors at Connecticut Children's, and I wanted to speak with you tonight about febrile seizures because it's something that a lot of people have had experience with in some way or another, either personally, their child, perhaps their relative, their neighbor. It's something that people have heard of, even if they haven't heard of epilepsy, or even if they don't know the relationship to epilepsy. So we're going to talk a little bit about this, and hopefully you can come away with some learning points. Just before I begin, I wanted to reinforce that I'm happy to take questions at the end. We have plenty of time, so if you can type those in the chat box, we'll address those at the end. So first of all, what are febrile seizures? The word febrile comes from the medieval Latin febrilis, which means pertaining to fever. So a febrile seizure is essentially a seizure with a fever. Now, there is a more concrete definition for febrile seizures, a more specific definition, which is a seizure in childhood specifically associated with a fever in the absence of another cause. And specifically for febrile seizures, what we need to rule out is we need to rule out brain infections, also called central nervous system infections. These are things like meningitis or encephalitis, which are infections of the meninges or the lining around the brain or the brain itself. And those are things that we worry about in febrile seizures. We also have to evaluate for electrolyte abnormalities. So things like sodium being too low or calcium being too high are both causes for seizures. And we rule out other defined causes. So for instance, if you had a fall and hit your head and then had a fever due to that, it's unlikely that this is a febrile seizure if you had a seizure in that context, but more likely related to the head injury that you sustained in the fall. So febrile seizures were first recognized as a separate entity from other seizure types in the mid-1800s. And this idea further gained prominence later in that decade in the late 1800s. And the question is why? Why this time? Well, it's thanks to this man who invented this thing, which is called Albert's short clinical thermometer. So in the late 19th century, Sir Thomas Clifford Albert invented something called the short clinical thermometer that took a temperature reading in 5 minutes instead of 20 minutes. So prior to this, it took a very long time to get an accurate temperature. It is short both in the duration, relatively short, both in the duration that it needed to take a temperature, but actually also how big the instrument was, because prior to this, some of the thermometers used to be very, very long, many feet long, whereas this was about 12 to 16 inches. So who gets febrile seizures? Well, it's a very defined population. First of all, febrile seizures are very common. So they occur in 2 to 5% of children, which doesn't sound like a lot, but actually it's the most common cause of seizure in childhood. And there are certain ethnicities and ancestries where it happens even more frequently than that. So the highest is actually in the Japanese population, where there are reports of it occurring 8 to 10% of the population. It's also increased in those children who reside in Finland or have Finnish heritage, as well as Guam. And the age of febrile seizures is really defined as early childhood. Now, the lower limit of the age where we see febrile seizures is a little bit gray, we'll say. Some people will say it's as long as they're a month or two old. Some people will say over 3 months. But the upper limit is really clear around 6 years, because most children who have febrile seizures will stop having them and outgrow their seizures by that time. And so we really think of febrile seizures as an entity that occurs between about 6 months and 5 years. Now, 80% of febrile seizures occur in children between 1 and 3 years old, and the peak incidence is right smack in the middle of toddlerhood, between 18 months and 24 months. And these are children who have a fever due to most likely viral illnesses, which we'll talk about. But 98% of the febrile seizures that occur in an illness happen within the first 24 hours. So this is not a disease where you have the flu for 2-3 days, and then on day 2 or day 3, you get a seizure. This really happens within the first days when a child is sick. Now, there are 2 types of febrile seizures that we talk about. There are simple febrile seizures and there are complex febrile seizures. Simple febrile seizures are defined by a single seizure in 24 hours, lasting less than 15 minutes, and has to be generalized in what it looks like. So a generalized seizure is a seizure that comes from both sides of the brain at the same time. So engages both hemispheres of the brain. And what that results in is a seizure that looks the same on one side of the body as the other. The most typical type of febrile seizure that we see is something called a generalized tonic-clonic seizure. Tonic means stiffening of the body, and clonic means shaking. So a child will go stiff briefly, usually with their arms and their legs outstretched or sometimes tight in towards their body, but their body is stiff. And then suddenly that stiffness starts trembling and turns to a rhythmic shaking, and that is called a tonic-clonic seizure. They're also called grand mal seizures, and these are the type of seizures that we see most often represented in the media, so in TV or movies. Complex febrile seizures, then in comparison, are defined by happening more than once in 24 hours, can be greater than 15 minutes, or they can have focal neurologic signs. And what focal means is it starts or is more impacted in one part of the brain. And so what that results in is something like one side of the body shaking instead of both sides, or after the seizure, having weakness on one side of the body, where a child may not be using their arm, or you may notice them limping on one leg. Sometimes what we see also more frequently is head going off to the side, turning to one side, and the eyes turning off to the same side. That is also another example of a focal neurologic sign. any of these features define a complex febrile seizure. Now, the little asterisk is there because when you have a very prolonged complex febrile seizure, it's called status epilepticus. And status epilepticus, in the setting of a febrile seizure, is defined as a febrile seizure lasting more than 30 minutes or shorter repeated seizures without regaining consciousness in between. And it has its own asterisks because it does have some different implications for prognosis and what it means for consequences of that, which we'll get to later. So why do children get febrile seizures? Well, the exact reason is not entirely clear. Unfortunately, we're not smart enough yet to say you have this change in your brain cells, which leads to this sensitivity, we'll say, to temperature at this age. Unfortunately, we're not quite there yet in our science, but what we do know is that developing neurons, which are brain cells, are vulnerable to any sort of body stress. And it's a combination of genetic predisposition to seizures, plus an immature brain during this age when the brains are vulnerable to seizure, and plus a fever, which is the stressor to the body. And a fever is necessary, but not the only factor in determining who gets febrile seizures. We know, of course, in children who do get febrile seizures, sometimes they only have one, but of course they have multiple other fever illnesses around that time, as all toddlers do. And sometimes we know as well that if a child does get one, they may have multiple, but then they often outgrow them as they go past that developmental age. So there's something to do with brain immaturity as well as a genetic predisposition. So what are the risk factors for having a first febrile seizure? We know that there are certain things that increases a child's risk of ever having one. So smoking, actually, maternal smoking while a child is in the womb, as well as maternal alcohol use prenatally, is a risk factor. Having a stay in the NICU, the neonatal intensive care unit, for longer than 1 month around the time of birth. Developmental delay, this is prior to a child having a febrile seizure. A family member with a history of a febrile seizure. And you can see that there is a higher number next to first degree relative than second degree relative. OR stands for odds ratio. So this is the risk of somebody who has a first degree relative with a febrile seizure having themselves a febrile seizure compared to somebody who doesn't have a first degree relative. And first degree relatives are things like parents or siblings. They also include children, but of course your children wouldn't have children by then. And second degree relatives are relationships like grandparents and aunts or uncles. It actually does not include cousins. So cousins would be a third degree relative. And then everyone's favorite risk factor is daycare. So in daycare, kids learn how to share their toys as well as their germs. So daycare attendance is also a risk factor for having febrile seizures. And the cause for that is just the increase in infections in minor upper respiratory illnesses that we know that children get when they attend daycare. So speaking of viruses and vaccines, there are certain viruses that are known to be associated with febrile seizures. The most common one is a virus called HHV6 or human herpes virus 6. A related virus, HHV7, is also to a lesser degree, another virus within that family that is related, but HHV6 predominantly plus HHV7 can be found in about a third of children who have febrile seizures. Influenza, of course, so the virus that causes the flu, and then adenovirus and parainfluenza virus. Those are HHV adenovirus as well as parainfluenza viruses are viruses that cause fever and upper respiratory symptoms, AKA your common colds. So your child will have a fever, they will have a runny nose, congestion, cough, maybe a sore throat, but things that there are no symptoms that differentiate one versus the other. Influenza we test for because we can do something about it. So there's the medicine that a child can take that can decrease the severity and the duration of having the flu. While human herpes virus is one of the viruses that is most commonly found in children who have febrile seizures, we actually don't test for it because it doesn't change what we do. And there's not a medication that we can give to try to make somebody's symptoms go away. Now, vaccines is the other worry about febrile seizures. If I do have seizures, if I have epilepsy, should I follow a normal vaccine schedule? What's the risk for febrile seizures? Well, there's only one vaccine that has been associated with an increased risk of febrile seizure, and that's something called the MMR vaccine, also known as measles, mumps, and rubella. So this is a vaccine that is given at the 12-month age, 12-month well check, as well as at 24 months. And if they look at the number of extra cases of febrile seizure that they get after this vaccine than at any other time, they see that there's 4 additional cases per 10,000 children who receive the vaccine. Now, that is if you get the vaccine on time at 12 to 15 months. If you wait until 16 to 23 months and you get the MMR vaccine, there's an additional 10 cases per 10,000 children. This actually supports the CDC recommendations that you should stick with an on-time vaccine schedule, and actually your risk of febrile seizure is lower than if you waited and spread out that vaccine. What we know is that the influenza, the flu vaccine, or Tdap, which is tetanus, diphtheria, and acellular pertussis, those are not, they do not give you an increased risk of febrile seizure. And notably, those are not live vaccines, whereas the MMR vaccine is a live vaccine. It's thought to be a little bit more immunogenic, meaning it causes a bigger response in your immune system. So of course, this would not be a talk during a pandemic without mention of COVID-19. So the question may come up and I wanted to answer it, but does COVID-19 itself increase the risk of febrile seizures? And the answer is not more than any other infection, interestingly. So children who have pre-existing epilepsy are at risk for breakthrough seizures, but there's not a higher risk for first-time febrile seizures than with any other virus that's out there, like the flu or like those other viruses that I mentioned that cause the common cold. Now, in the literature, there was one report of a child who did not have epilepsy who presented in febrile status epilepticus, meaning a very prolonged seizure. However, this was a single case report, and it has not borne out across the literature that children are more prone to this if they get COVID-19. Part of that rationale is that febrile seizures are seen at a certain developmental and maturity age of the brain. So again, that peak age is between 1 year and 3 years, where 80% of febrile seizures happen. However, 1-year-olds to 3-year-olds actually don't get COVID-19 very much. And so some of this is the lack of exposure that they have, not in exposure because they are exposed, but lack of infection rather to COVID-19 may be related for some of this. Now, we know that family relatives of children who have febrile seizures are at higher risk, and there's a clear genetic predisposition. However, it's certainly not 100%. And while it can run in families, if it doesn't, there's still a increased risk of a sibling having febrile seizures. So for instance, if a child has a febrile seizure, the risk for their sibling is 10 to 45%. Now that seems like a broad range, but these are based on different studies, some smaller, some larger. But even if you looked at twin studies where they looked at what is the rate of identical twins having these febrile seizures, that only goes up to slightly above 50%. So there are other things at play besides just a genetic disposition. And we know that even if it is genetic, there's not just one gene that influences somebody's tendency for a febrile seizure. There are a few genetic syndromes that have temperature sensitivity and that can first present with a febrile seizure. And I just wanted to mention two examples. One example is called GEFS plus. That's how we refer to it as epileptologists. It stands for genetic epilepsy with febrile seizures plus. The plus is because they have other things, such as other seizure types. It's an autosomal dominant syndrome, meaning that it occurs in every generation. And it has something called variable penetrance, which means that even if two people have the same genetic difference, they may be differently impacted. One person may be more severely impacted, the other person may be just minorly impacted. So people's symptoms are not the same. If you looked at a big family who had GEFS plus, what you would see is about a third of family members have febrile seizures only. They don't have other seizure types. However, their febrile seizures may happen frequently, relatively. Instead of just one or two, they may have recurrent febrile seizures, and they may last beyond the normal 5 or 6 years. A third of family members will have febrile seizures, but will also have rare generalized seizures outside of the times that they have fever. The most common being generalized tonic-clonic seizures that we talked about, of stiffening and then shaking movements. We also see other types of generalized seizures like myoclonic seizures. Myoclonic seizures are quick little myoclonic jerks that everyone has when they are falling asleep and they suddenly feel like they're falling and their body jerks awake. That quick, very rapid little jerk that you have is called a myoclonic jerk. And sometimes when they're associated with an abnormal brain discharge, they're called myoclonic seizures. So a third of family members will have febrile seizures plus rare afebrile seizures of a different type. They, though, will then also outgrow their seizures after childhood. And then lastly, a third of family members will develop a different genetic epilepsy syndrome in addition to febrile seizures. So for instance, childhood absence epilepsy, which is marked by many absence seizures per day. Those are absence seizures are the ones where children can stare off and kind of zone out. And then also another syndrome called epilepsy with myoclonic astatic seizures, also called Dose syndrome, or in the native German, Dose syndrome. All of these, though, have multiple different mutations. So if you look at different families who have GEFS plus, who have the same presentation, there are many different changes that go on in their genes and in their brain. So we see that there are multiple sodium channel mutations and then also GABA receptor mutations. So GABA controls another electrolyte called chloride. Called chloride. So both sodium, chloride, and other electrolytes like calcium are things that actually cause the brain to fire. So the brain cells fire with electricity, but the reason why they fire in the first place is due to shifts in electrolytes like sodium and like chloride, which is controlled by your GABA receptors. Another genetic syndrome that a lot of people may have heard of is called Dravet syndrome. Dravet syndrome is a developmental and epileptic encephalopathy. What that means is that the seizure severity and the severity of the abnormal brain discharges that are going on frequently cause the patient to have developmental delay and regression. Now, most patients with Dravet syndrome have a mutation in a gene called SCN1A, which controls a sodium channel. And the hallmark of Dravet syndrome is that they all start very similarly, that patients with Dravet syndrome have a febrile seizure in early infancy. We're talking about that early age of the spectrum, like 6 months, and it's usually prolonged. So not just 1 or 2 minutes, which is most febrile seizures, but we're talking 15 minutes, 20 minutes, and they often only affect one side of the body. So early complex febrile seizures that may be prolonged and only affect one side of the body is a presentation for a lot of children with Dravet syndrome. Dravet syndrome, uh, Children with Dravet syndrome develop other seizures without fever by age 1 year old, and ultimately their seizures are treatment resistant. However, always still temperature sensitive. So patients with this syndrome, when they have a fever, are likely to go into febrile status epilepticus again. Now, going back to febrile seizures, when somebody does have a febrile seizure, what sorts of evaluations should occur for them? The most important is to do a focused history and physical examination to try to determine the cause of the fever. The emergency room docs, who are the most likely ones to be seeing this first, should be asking things like a description of the convulsive episode. How long did it last? They'll be getting at things like any focal signs, such as only one side of the body shaking or weakness afterwards. They should be asking about a personal history and a family history of seizures, both febrile seizures with fever and also afebrile seizures. They should be asking about any signs of illness to try to figure out, is the child actually sick? And also, did they get any antibiotics? And the reason why antibiotics are important is because antibiotics can mask a more serious infection. And we touched on this a little bit, vaccines. They should be asking, have you had any vaccines recently? And also, is the child up to date on vaccines? The risk of meningitis or encephalitis, which are those brain infections that we worry about, are higher in children who are not up to date with their vaccines. And there are two in particular: Streptococcus pneumonia and Haemophilus influenza type B, are two infections that cause meningitis and encephalitis that are vaccine preventable. Now, if the child had a simple febrile seizure and is well appearing, there is no additional workup that is needed. That includes things like blood tests. Now, a lot of emergency rooms will do an evaluation, including something like a blood test to make sure that there are no electrolyte disturbances, but they haven't really found that to be very effective in terms of finding abnormalities that would explain a seizure. So if somebody has a fever and they know the cause, you actually don't need additional blood work. Now, the doctors there may do some additional tests to determine what the cause of the fever is, and that they can still do. So things like checking the urine for urine tract infection, or doing a nasal swab to check for different viruses, including flu. So this question of brain infection is an important one. So does a fever with a seizure mean that somebody has a brain infection? There's actually no increased risk of meningitis in patients who had a simple febrile seizure. There have been multiple studies over the years, one of the biggest of which is a case series of about 500 children who had meningitis over a 20-year period. And there were no patients who presented only with a simple febrile seizure. All of the patients who had meningitis had additional signs, including things like a change in their mental status. So they are confused or they are excessively sleepy. They had a prolonged seizure or multiple seizure, so febrile status epilepticus, or they had a rash, which is a common finding in children with meningitis. So when is a lumbar puncture indicated? To take a step back, a lumbar puncture is a procedure where a needle is inserted between the vertebrae in the lower spine to get a sample of the spinal fluid. And the spinal fluid is the same fluid that bathes the brain. It's actually all one connected sac. It's called cerebral spinal fluid. And if somebody has an infection in their brain, they will have abnormalities in the spinal fluid. So that's the way that we diagnose it. So when do we need to get a lumbar puncture then? And the answer is when you can't trust your other examination signs. So in a very young child, so less than 12 months old, and they have incomplete or unknown vaccine status for these two bad bugs that cause meningitis and encephalitis, that's when we get worried about missing an infection in the brain. Or the other times where we get worried is if somebody had antibiotics already. So for instance, if a child was diagnosed with an ear infection a few days earlier and was on antibiotics for 2 days and then still had a fever, still had a febrile seizure and presented to the emergency room, we would be worried that there would not be other signs of meningitis because they would be masked by the fact that the patient already had treatment. And then the third thing that is not on here, but it is implicit, is that if a patient ever didn't look well, so if they weren't sitting up, if they weren't recovering, if we were worried about them, if they had changes in their heart rate or their blood pressure, those would all be things that would push an emergency room doctor to look for a brain infection. Now, what about a complex febrile seizure? Does that require a different evaluation? And the answer is there's actually no consensus on what to do in this situation. Should somebody do imaging like a brain MRI? Well, in a case series of over 500 children who had first-time complex febrile seizure, less than 1%, only 4 of 526 had a clinically significant intracranial pathology, meaning they found something that was bad and they had to act on it. 3 of those 4 had an abnormal neurologic exam. So now we're talking 0.1% who had an abnormal image with an initial complex febrile seizure. With those numbers, the answer is no, you don't have to do imaging. Do you need to do an EEG? So an EEG is an electroencephalogram. That's where they put the electrodes on your head and take a look at your brain waves. Well, an EEG does not change the acute management of complex febrile seizures, meaning it doesn't change what you do in the hospital or in the emergency room. It actually also does not predict seizure recurrence risk. It could be considered as an outpatient if there are multiple risk factors for epilepsy, however. For instance, we'll talk about those, but for instance, if a child has developmental delay or if there's a family history. And should you do an examination? The answer is always, that's the one thing you should be doing in all cases of febrile seizure, because if you have an abnormal exam, that would push you to get a picture of the brain with a brain MRI or to do a lumbar puncture to look for something like a brain infection like meningitis or encephalitis. And once a child has a febrile seizure, the question always comes up, well, is it going to happen again? So the answer is 1 in 3 children who have a febrile seizure will have it come back again. So a 33% chance of recurrence. There are 4 risk factors for seizure recurrence. The most important predictor of seizure recurrence is actually age. So if the first febrile seizure occurred less than 18 months old, then that's a strong risk factor for it coming back. And actually, if you're less than 1 year old, you have a 50-50 chance of having a febrile seizure return. If you're greater than 3 years old and you have a first-time febrile seizure, it's actually only a 1 in 5 chance of the seizure coming back. Other risk factors include having a fever for less than 1 hour before the seizure, meaning your fever starts right away and you start having a febrile seizure right after that. If you have a first-degree relative with a febrile seizure, so again, parents or siblings or children, or if you have a temperature less than 104 degrees, which sounds hot to you or I, but actually anyone with children will know that they get up there to 103, 104 pretty quickly. Now, the overall recurrence depends on the number of positive risk factors that you have. So overall, the chance is 1 in 3, but actually if you don't have any risk factors, your chance is less than 1 in 5. And if you have 1 risk factor, it's 1 in 4. And then if you go 2 risk factors, that's when you're 1 in 3. And this is the 2-year recurrence risk, though overall, most febrile seizures, if they do recur in about 1 year. What's interesting about this is that there is no difference in recurrence risk if the seizure was a complex febrile seizure or a simple febrile seizure. And we'll touch on this a little bit more in a bit, but antipyretics, which are fever-reducing medicines, such as acetaminophen, which is Tylenol, or ibuprofen, which is Advil or Motrin, they actually do not reduce the recurrence of febrile seizures. And this is a reminder to myself, if anyone has aspirin at home for themselves, you should never give a child aspirin during an illness with a fever. There's a rare side effect that can happen to children, but does not happen to adults. So avoid aspirin in children unless otherwise directed. So after they have a febrile seizure, will a child go on to develop epilepsy? Well, let's take a step back and say, well, what is epilepsy? Epilepsy is a disease of ongoing susceptibility to having spontaneous seizures. So these are seizures without a trigger. So without a head injury, without a fever. This is defined actually as having more than one unprovoked seizure, having one unprovoked seizure with an abnormal EEG, which suggests to us that there's an increased seizure risk, or having a diagnosis of an epilepsy syndrome. There are certain risk factors for progression to epilepsy, which are different actually than the risk factors for febrile seizure recurrence. There's some overlap, but most of them are different. So first of all, developmental delay. So if this is a child who's not a neurotypical child before they have their first febrile seizure, if they have autism or other neurologic issues, if they have developmental delay, they are at higher risk of progressing to epilepsy. If there's a family history of epilepsy, so not just simple febrile seizures, but afebrile seizures. If they have complex febrile seizures, especially more than one, if they're more than 3 years old at the time of the first febrile seizure, or if they have a fever less than 1 hour prior to the seizure. This last one is a risk factor both for progression to epilepsy as well as recurrence of a febrile seizure. So what are the numbers? What is their actual future epilepsy risk? So if we took a look at the overall population, the population prevalence of epilepsy is about 1 to 2%. If you have a simple febrile seizure, this goes up just a tiny bit to 2.4%. Essentially, it's the same. You do not have an increased risk of epilepsy if you have a simple febrile seizure. If you have a complex febrile seizure, this goes up to about 3 times the risk at 6%. So 3 times the risk sounds like a lot, but if you look at the actual number, we're still only talking around 5 to 6%. If you have more than one feature of a complex febrile seizure, your risk actually goes up pretty significantly. So here are the 3 features that we talked about again. So more than 1 in 24 hours, longer than 15 minutes, or focal neurologic signs. If you have more than one of these, then your risk is about 1 in 5 that you'll go on to have epilepsy in the future. So overall, for the vast majority of patients who have febrile seizures, their risk of future epilepsy is small. We're talking 2 to 6%. Rarely is it bigger than that, but it does happen. So if febrile seizures are so benign, then why do some children later develop epilepsy? Well, the thought is that febrile seizures may actually just be the first sign of an underlying epilepsy in these children. This child who had febrile seizures and then the next year went on to develop epilepsy, or 6 months later went on to develop epilepsy where they had spontaneous seizures without a fever, it's probably that that child already had a predisposition to seize, and the fever lowered their seizure threshold, meaning it made it easier for their brain to have a seizure in the first place. I mentioned 2 of those genetic syndromes, Dravet syndrome and GEPS+. The first presentation of both of these epilepsy syndromes is a simple or a complex febrile seizure. So sometimes we do have febrile seizures that progress to a fever. However, in the majority of cases, we're talking a very small or insignificant increase in the risk of epilepsy, so 2 to 6%. So what does it mean long-term if my child had a seizure with a fever? Well, the mortality is no different in simple febrile seizures. So the number one thing that parents say when they see a febrile seizure in their child is that they think that their child is going to die, because seizures are scary. And I'm a neurologist, I'm an epileptologist. I don't like to see them either. I think it's scary too. And it's very understandable when you don't know what's going on. You don't know if the seizure is going to stop, to say, is my child going to die? But the answer is no. If they have a simple febrile seizure, there's no increased risk of mortality compared to the general population. In children who have complex febrile seizures, I wish I could say the answer was no, there's no difference. In truth, there's a very slightly higher rate of mortality over the next few years, but that's due to the fact that children who have complex febrile seizures are at higher rate of developing epilepsy and have higher rates of other neurologic abnormalities. If we look at something like their intelligence, any behavioral issues, and their academic achievement down the road, children who have febrile seizures don't do any worse than those who didn't. And there's no difference between simple or complex febrile seizures. And while some studies only have 500 patients, there are multiple studies where people have 15,000 to 55,000 children that they followed for 10 years. And we did not find any difference in simple or complex febrile seizure intelligence or academic achievement. So all of this being said, it's just something that you can actually prevent. Antipyretics, which are the fever-reducing medications, would seem like the obvious choice to try to prevent a febrile seizure. But actually, there's been many studies looking at this, and there's no evidence for prevention when all the literature is taken together. So your Advil, Motrin, which is ibuprofen, your Tylenol, which is acetaminophen, helps make kids feel better during their illness, but is not going to prevent the child from having another febrile seizure in the future. And if you stay on top of it and you try to give them Tylenol and ibuprofen alternating every 6 hours as directed by your pediatrician, they may still have a febrile seizure. So don't beat yourself up about it. There was a recent trial in Japan, actually, that looked at 400 children giving rectal Tylenol every 6 hours for 24 hours. And they did find a slightly decreased short-term recurrence. So from about 20% down to 9%. And this is recurrence within the same illness. Now, we think of risk and benefits of medicines as, how many patients do you have to treat in order to prevent one instance of a febrile seizure? And we think of that as, in medicine, as something called the number needed to treat. Well, this is a positive study for a fever-reducing medicine. But even this one, the number needed to treat was 7, meaning that you have to treat 7 children to prevent one febrile seizure. And for most of us, the math doesn't add up. Now, there have been a few other positive studies, but again, there are many more negative studies, meaning that they did not find prevention with a fever-reducing medicine. And overall, fever-reducing medicines don't help. They've also tried something called intermittent or daily dosing of an anti-seizure medicine. In particular, there's been trials of a medicine called phenobarbital and another one called valproic acid, which people call Depakote. And there have been trials of intermittent diazepam, which is Valium. So giving intermittent diazepam only when somebody has a fever. Do they work to prevent seizures? They do. Are they worth it? Actually, probably not. So in all of these trials, the side effects were not worth the possible benefit of preventing a seizure. So people who got intermittent Valium sometimes had trouble walking, they were dizzy. People who got phenobarbital or valproic acid sometimes had liver abnormalities or were very sleepy. In all, prevention with an anti-seizure medicine is usually not needed unless febrile seizures are recurrent or persistent, meaning they have very recurrent and very long ones. So in general, for this, the risks outweigh the benefits. And there's actually, lastly, a few interesting articles about zinc being related to febrile seizures. And the reason is because in blood and cerebral spinal fluid, the levels of zinc are found to be a little bit lower in children who have febrile seizures. It's not clear why that is, but multiple studies have found when you try to give people zinc, it actually does not prevent them having febrile seizures. So in summary, there's not actually very good prevention or any prevention that we can do. So, but there doesn't mean there's nothing that we can do. So what do you do if somebody has a febrile seizure? Well, the same thing that you would do for a non-febrile seizure, so no fever with a seizure. You want to protect the child from injury. Lay them down in the recovery position, which is this position on their side. Support their head and move away any objects in the environment that they might hit or be injured by. We don't restrain people who are having a seizure and never put anything in their mouth. And you should always call 911 if the seizure is lasting longer than 5 minutes. And the caveat to that advice is it's never wrong to call 911. So of course, the first time somebody has a seizure, you should always call 911. And even if they've had one of these febrile seizures before, if you're not comfortable watching them at home, it's never wrong to call 911. So we mentioned complex and simple febrile seizures, but we also mentioned that there's this prolonged febrile seizures that may have additional consequences. So short, self-resolving, simple febrile seizures do not have long-term consequences. Complex febrile seizures have a very small increase in the rate of epilepsy. But what about febrile status epilepticus, which is again the febrile seizure that lasts longer than 30 minutes? Why do we care about this? Well, in adults, the #1 cause of seizures is something called mesial temporal sclerosis, which is scarring of the hippocampus and other structures inside the temporal lobe. So this is a picture of your brain and kind of cut straight down the middle. This on this side and this kind of triangular piece on this side, these are your temporal lobes. And you can tell on this side where the red arrow is pointing, you see a smaller hippocampus that's a little bit scarred down compared to this side where it's nice and plump. You can see extra darkness around here. This is an example of mesial temporal sclerosis. And there's an association between febrile status epilepticus and the development of this. Overall, about 15% of adults with epilepsy have a history of febrile seizures. So there is some relationship, but it's not clear which patients with febrile seizure will go on to develop this. So enter this big important study in the world of febrile seizures called the FEBSTAT study that was published in 2014 initially. So the FEBSTAT study stands for Febrile Status Epilepticus, and it looks at febrile status epilepticus as well as consequences of that. It studied about 190 children who had febrile status epilepticus, which for them went on an hour or more between 2002 and 2010. And there were some important results from this study. First of all, the time from seizure onset to the first medication was 30 minutes. It's a long time. And the seizure overall lasted about 90 minutes. The time from seizure stopping after they gave the medication was an additional 38 minutes. And the initial dose of benzodiazepine, which is a medicine like lorazepam, which is Ativan, or diazepam, which is Valium, or midazolam, which is Nazolam. This initial dose of seizure rescue medicine was too low in about 20%. They also found that decreasing the time from seizure onset to the dose of the rescue medicine led to a significantly shorter seizure duration. So in conclusion from this study, febrile status epilepticus rarely stops on its own, and all of it needed medication. It's important to treat quickly as it's going to stop the seizure sooner. And because of that, pre-hospital treatment protocols should be standardized. Well, prior to this, there actually was no standardization in pre-treatment hospital protocols. So different EMS or ambulance services had different treatment protocols. And also this study brought to light that we weren't treating fast enough, from first seizure onset to first medication. And we're also not treating appropriately, that the dose of the benzodiazepine is too low. So actually changes have been made due to this study. This study actually also allowed us to figure out some other information about febrile seizures. So the tidbit about HHV6, so human herpes virus 6 and 7, accounting for about a third of cases of all febrile status epilepticus. That was from this study. We also know that there's about a 20 to 30% chance of recurrent febrile seizures, recurrent febrile status epilepticus if you've already had one episode. And lastly, that those who do have febrile status epilepticus have a risk for future memory problems. Now, children who do have febrile status epilepticus in the study underwent imaging and EEG, and they found that the EEG was abnormal in about half of children, with the most common finding being that there was slowing over the temporal region. And slowing can be a sign of underlying brain dysfunction. When they saw that brain dysfunction, whoever had slowing also had associated changes in the T2 signal, which is a change in their MRI signal. Overall, about 10% of children did have MRI changes in that temporal lobe region, but not all those patients went on to have epilepsy. What they found is that actually the makeup of different inflammatory markers may be a better predictor of who gets that hippocampal scarring and who ends up with epilepsy. And ultimately, the results from this study show us that while a history of febrile seizures are common in adults with epilepsy, it's not actually clear who's at greater risk to develop epilepsy after febrile status epilepticus. So in conclusion, talking about febrile seizures, I hope that you come away that febrile seizures are really common, but there's a peak age when they happen, which is a peak of 1 to 3 years old. And we really don't see them outside of the window of 6 months to about 6 years. Now, the vast majority of children have simple febrile seizures and they only have one, but there's no implications for cognition or development. And also antipyretics, which are fever-reducing medicines, don't prevent recurrence. Complex febrile seizures can also occur and have a slightly higher risk of epilepsy long-term, but no cognitive differences. And rarely, people do go on to have epilepsy after a febrile seizure, and these are more likely to be those people who had febrile status epilepticus, which is a very prolonged seizure, or who have a genetic predisposition to fever anyways. And above all, a history and a physical examination is really the only evaluation needed for most patients. So with that, I'm happy to take any questions that you have about febrile seizures. And Monica, if you would like to help me out and let me know if there's anything in the comments that I can answer.
Sure, thank you, Dr. Worden. That was really interesting. And I'm just curious, do you know the percentage of people with febrile seizures that it is genetic for?
So they don't test genetics on children who have simple febrile seizures or complex febrile seizures. They would only consider it, and we would only consider testing if there was a strong family history of it. And even in that case, it may not be something that would be covered by insurances, and so families would have to pay out of pocket. And the reason is because if you're having only febrile seizures, again, most children only have one, or sometimes they'll have a few, but again, they outgrow it, and the developmental consequences, the consequences for thinking and learning are usually are are usually none or very limited. And so children do quite well with febrile seizures. And so we don't do genetic testing in those circumstances.
Mm.
If somebody did have a family history that suggested that they had something like GEFS plus, so genetic epilepsy with febrile seizures plus, where there are many people with febrile seizures and the febrile seizures happen frequently and last longer, in that circumstance, I would consider genetic testing.
Mm. Thank you. And it was interesting what you shared about Dravet syndrome and how febrile seizures are kind of the first are the first type of seizure that those that go on to develop Dravet experience. So does that mean that for someone that has Dravet, do they have both epilepsy seizures and febrile seizures?
That's a great question. So febrile seizures is a specific term that we use for this entity of seizures only in the setting of fever in this developmental age that, again, don't have consequences for future things like learning or development, and that kids usually grow out of. So sometimes when somebody has a single febrile seizure, and it may be a complex febrile seizure or a prolonged one, we still give them that label initially because we don't have any evidence yet that they're going to go on to develop something else. So a child who has Dravet syndrome with their first seizure, if it was a febrile seizure, they would probably just be called a febrile seizure. But then as the story becomes clearer with time, and certainly if they have any seizures without a fever, we call those afebrile seizures, then the term febrile seizure would no longer apply, and we would say they just have epilepsy.
Okay, that makes sense. Yeah, even and we know for the even for the average kid that has epilepsy, that certainly illness or fever can trigger, right?
Exactly. Yep. And we would not call it a febrile seizure in somebody who already has a diagnosis of epilepsy, even if they had a fever with that.
Okay. Interesting.
Yeah.
And then I have one last question, which isn't actually directly related to febrile seizures, but you mentioned that for those that go in febrile status epilepticus, that they may experience memory problems in the future. So would that be the case for epileptic status epilepticus as well, like where someone's, has a seizure, let's say for 15, 20 minutes, that even if it's only one seizure, that can impact their memory in the future?
Does that have long-term impact? Yeah, that's a great question. Febrile status epilepticus has a much longer time frame where it needs to go on for before we say, okay, that's too long, that's status epilepticus. So in somebody who does not have a fever but has epilepsy, we would call status epilepticus about, nowadays we call it 5 minutes after a convulsive seizure, and longer for non-convulsive seizures. There's not really a clear cutoff for non-convulsive seizures, but if somebody is having a full body convulsion and it doesn't stop on its own within 5 minutes, we call that status epilepticus, and we would recommend giving a rescue medicine. For febrile seizures, we don't use that term until half an hour, and even longer. And the reason is because we do feel like it's a different entity, but clearly there is some change to the brain that happens from having this ongoing seizure activity from febrile status epilepticus. We know that happens also in regular status epilepticus without a fever. We don't know at what time point it happens. It's probably not something so short as 5 or 10 minutes. We say that 5-minute definition because seizures that don't stop on their own within 5 minutes are harder to stop on their own. And that's why we use that cutoff to give medicines. But we know from animal studies that you don't get changes to the brain and that might lead to brain injury until a longer period, something like half an hour or an hour. There's not clear studies in humans as to when that cutoff is, though.
Okay. Thank you.
All right.
Any other questions for Dr. Worden? That was such a great presentation, really. You covered so much, and it was relatively easy to understand, so good job.
I try to make sure that everyone can understand it, because it's something you should be able to go home and explain to other people. And if I didn't do a good job, then then you wouldn't be able to.
Right. Thank you.
You're very welcome.
That was a great presentation. Thank you so much. Very informative.
Oh, you're welcome.
Well, thank you, Dr. Worden. And just a reminder to those listening that this is has been recorded, and it will be available on our Facebook page and also on our website, which is epilepsyct.com. So thank you once again, and thank you all for those that have joined us this evening. And we look forward to hopefully doing this again at some point with Dr. Worden specifically.
Great. All right. Thank you very much, Monica.
Thank you.
Night.
Good night.